Good afternoon. My name is Jill Dyken, and I'm ATSDR's Associate Director for Science. Today, I'm going to be talking about how ATSDR evaluates per and polyfluoroalkyl substances, or PFAS, through our standard public health assessment, or PHA process. I hope this talk will be useful for ATSDR and apple tree health assessors who are or will be working on PFAS evaluations, those who review the work, and those who help explain the findings. In today's talk, I'm going to give an overview of our process and some of the unique issues with evaluating these substances at sites. I'll also talk about recent changes in PFAS science and regulation that may affect our evaluations. While we still haven't worked out all the answers, I can try to give some practical advice for moving forward with evaluations in the midst of changes. Today, I'm going to give you just a couple background slides before jumping into how PFAS are evaluated in the PHA process. The process hasn't changed, but I will talk about some pretty significant science and regulatory changes in just the past year that mean our site evaluations can't just follow what we did in the last few documents. I'll try to give some thoughts on how we may incorporate new information into our evaluations, but at this point, we don't have a one-size-fits-all solution on how to proceed with site evaluations. PFAS are a group of thousands of man-made chemicals that have been used in many applications since the mid-1900s. Their special properties made them useful in a wide range of consumer products, and they have also become common contaminants in air, water, or soil, especially around places where they were made or specifically used. They're of concern because they break down very slowly in the environment and in the human body, and are of growing concern for several health effects. This slide has pictures of two of the most common PFAS used in the past, PFOA and PFAS, and the schematic on the right illustrates that many other PFAS with various chemical structures are being discovered. In the past few years, ATSDR has been involved in many activities related to PFAS. If there's time at the end of this presentation, I'll share some updates on these. But my main topic today is the site-specific evaluation of exposures we do as part of our core public health assessment and health consultation work. We have several ongoing evaluations at sites led by apple tree partners, our regional offices, or headquarters. I'm going to lay out the basic process today in hopes this will help your work or your understanding of our work. The science behind PFAS is changing pretty rapidly still, and there have been several recent regulatory actions that affect our process and may change the way we present conclusions. But the general framework of how we evaluate PFAS hasn't changed, and I believe will stay pretty much the same for the foreseeable future. So today I will give you an overview of the most important steps and some considerations when applying our process to PFAS sites. If you have any specific nuts and bolts type questions, I can try to take a stab at them too. Just for those who may be less familiar with ATSDR's process, I'll briefly summarize the overall picture of our PHA process. This process was designed to answer the difficult question of whether the levels of chemicals in a community's environment coming from a site could harm their health and what should be done to protect public health. ATSDR starts by gathering information about the site. We use environmental sampling data and information on what people in the community do around the site and what their concerns are. With these inputs, we do a detailed evaluation to decide if exposures could harm the health of community members. Based on that evaluation, we make conclusions about whether harmful exposures are occurring and what should be done to protect public health. Today, I'll be talking mostly about this middle circle. ATSDR has standardized the steps we take in performing this evaluation to make sure we follow the best science and reach consistent public health decisions. The bottom line up front is that really the process for evaluating PFAS is the same as for most of the chemicals we evaluate. This slide summarizes the basic steps of the evaluation part of the PHA process we follow for all of our public health assessment work. We organize data and decide which exposure pathways are important to consider. We screen the data using ATSDR comparison values, or CVs. We estimate doses and compare them to health guideline doses. And when doses are higher than health guidelines, we do an in-depth toxicological evaluation to determine if harmful exposures could be occurring. For PFAS, it's especially important to consider potential mixtures effects, since there are so many different PFAS, and many of the PFAS we know about have effects on similar organ systems. So the process is pretty standard. There are some nuances specific to PFAS I'll discuss, but the main factor that has made PFAS so complicated to assess is the changing science and regulation. For the past several years, PFAS has been an intense area of research, adding to the toxicological studies we have to consider, and in many cases lowering the exposures we are concerned about. EPA has completed final toxicological reviews for several PFAS that have changed the CVs and health guidelines. So we can't just look at what we did last year and follow that evaluation. And this is continuing, so the information I'm going to show you today may change soon. So first I'll talk about some considerations for PFAS that we've learned from our previous evaluations that may come into play in your evaluations. I'm focusing mostly on considerations from the viewpoint of drinking water evaluations. This is what I know from the site evaluation I worked on. But also PFAS in drinking water has been the biggest exposure concern we have looked at in the past few years. I know several projects and site teams are looking at other potential exposure pathways from fish or game to dust and soil and so on. Some of the info I'm sharing today might apply to these pathways too. At the very outset of your work on a PFAS site, organizing the data for PFAS can pose some challenges. Labs using different names or reporting conventions for the same PFAS or inconsistency in what units are reported can lead to errors in describing the contamination. And this could affect the overall evaluation. I've included a link to the Interstate Technology Regulatory Council, or ITRC, materials on PFAS, which I found to be very helpful for understanding these issues. It's pfas-1.itrcweb.org. A related issue is the expanding list of PFAS that labs are able to analyze for. For example, the data set I received for a site I worked on had 56 different analytes listed for PFAS. It can be a bit overwhelming if you don't have a plan for handling it. A final issue that I've put under data organization is that the exposures you're trying to describe with the data can be quite complicated. For public water systems, there could be multiple wells contaminated at different levels. The mixing and distribution might mean different areas of town received more contaminated water than others, and you might have to do additional analysis to model the exposure levels. If you have sampling results for private wells, it's complicated in a different way because each well is different. You have to decide how to present the data in a way that considers both the household level of exposure and the overall community impact of those exposures. I won't go into the details of the exposure pathway analysis, but just remind you that we look at 5 elements: a contaminant source, environmental fate and transport, exposure point, exposure route, and exposed population. All 5 of these elements have to be present for the pathway to be complete. If we have measurements showing PFAS in drinking water, we can assume a complete pathway as long as people are able to use that water, whether it's from a private well or a public water system. I'll just talk briefly about exposure route. That is how the PFAS gets into the body, which could be by swallowing it, ingestion, breathing it, inhalation, or taking it up through your skin, dermal exposure. Up till now, ATSDR drinking water evaluations have typically focused on ingestion of the water for two reasons. First, most PFAS, at least those we have good toxicological information on, don't evaporate readily from water. And second, several PFAS in water are in a form that does not easily penetrate the skin. So while inhalation and dermal exposures might occur, we have to date assumed that the PFAS exposure from drinking the water contributes far more to exposure than from showering, bathing, or other household uses. However, as we learn more about PFAS and identify new PFAS of concern, this could change. In the future, ATSDR's shower model may fill an important role, as it can estimate both inhalation and dermal exposures for PFAS. Right now, we don't have toxicological data to evaluate the sulfonamide PFAS that are somewhat volatile, and most PFAS we know of have low dermal absorption from water. But this could change as we learn more about PFAS and identify new PFAS of concern. For now, you can use the shower model as a check that inhalation and dermal exposures are minimal and not a concern. You can find information on the shower model on the resources page of ATSDR's online Public Health Assessment Guidance Manual on the ATSDR website. I'd also like to note that the understanding of dermal uptake of PFAS is evolving, and this may turn out to be something we need to consider more fully in the future. Dermal uptake from other media or from consumer products might be different than from water. And what we know about dermal uptake of PFAS in water may change as we get better analytical methods and more understanding of what might be physiologically relevant. After the data is organized, the next step is screening. That is comparing each PFAS with its corresponding ATSDR comparison value, or CV. For this, you use the maximum detected value of each PFAS and compare it with the recommended CV in our Public Health Assessment Site Tool, or FAST. For many of our sites, this step allows you to screen out chemicals from further evaluation. But for PFAS, this is not completely true. PFAS that are below their CVs will screen out for an individual analysis, but we need to consider doing a mixtures analysis if there are multiple PFAS detected at just a tenth of their CV. And those PFAS that don't have CVs may also be retained for a qualitative discussion in the document. This will be helpful to show that we considered all PFAS that might contribute risk, especially since a CV for that PFAS might become available at a later date. Finally, I'll mention here the new CVs for several PFAS, and I'll talk more about these later. Some of the new CVs are so low, close to detection limits, that almost any detection will exceed the CV. You might wonder why we would bother screening. I feel the screening step is still helpful for you to organize the findings for your site and get an idea of which PFAS are most prevalent, the range of concentrations, and so on. And I also feel like the screening tables are a helpful presentation for readers who want a quick initial picture of the site. After screening, the next step is to estimate the doses possible from exposure to the PFAS measured at the site. We do this by using the appropriate exposure point concentration, or EPC, and assumptions about ingestion and body weight for the exposure scenario you are evaluating. The EPC should be a high-end estimate of the concentration, either a 95% upper confidence level or the maximum that people would be exposed to over the time frame of interest. The appropriate time frame and EPC to consider depend on your site, what time periods you have data for, and other factors. Data coverage and quality is really important. For example, if you're interested in chronic exposures, you may still have to use a shorter term EPC because there might not be frequent enough samples collected to really be sure you're capturing a good longer term average. Sometimes there are so few data, it ends up the maximum has to be used regardless of the time frame. Another thing you need to consider when determining the EPC is the system the water is provided by. A public system might have a complex mixing and distribution system that could result in different consumers having quite different exposures. Private wells, on the other hand, could have different contamination from well to well. So you really want a specific EPC for each well. A little later today, I'm going to discuss some practical issues with this part. ATSDR has guidance on appropriate exposure assumptions for various scenarios, which should be used to calculate doses for the scenarios at your site. The guidance is available on the resources page of ATSDR's online Public Health Assessment Guidance Manual on the ATSDR website. Although some sites may have special exposure populations, most sites will involve an assumption of residential type exposures, so all the standard age groups and assumptions would need to be included. At the bottom of this slide, I've shown the equation for calculating the dose from drinking water. And this equation shows dose in micrograms of contaminant per kilogram of body weight per day. The same general equation will be used for different units too. Later, I'll show concentrations in nanograms per liter. Of course, for the dose calculations, you will end up with multiple doses for each PFAS to represent the different age groups and exposure scenarios at your specific site. Once you have a dose, the next step is to see how it compares to the health guideline of interest, that is, the minimal risk level or the reference dose. This is easiest to do by calculating a hazard quotient, the estimated dose divided by the health guideline. There are two things you're looking for once you've got your set of hazard quotients for all your PFAS. First, for any hazard quotient greater than 1, you'll retain that PFAS and do an in-depth toxicological evaluation for it. The other thing you're looking for is if there are more than one PFAS with hazard quotients above 0.1. And if the sum of those hazard quotients that are greater than 0.1 is greater than 1, you will do an in-depth toxicological evaluation of the mixture. For the in-depth toxicological evaluation, you will consider the studies used to derive the health guideline and other studies that report similar effect levels. These are the sensitive endpoints you will want to consider. If your estimated doses approach or exceed these effect levels, it could be a concern. You can find information on studies and effect levels in FAST at the bottom of the substances CV and health guidelines page for that contaminant. For mixtures, you'll consider if the health endpoints are similar for the mixture components and include the possibility of additive effects from exposure to the mixture. The in-depth evaluation also considers the carcinogenicity of each contaminant and includes an estimation of the increased lifetime cancer risk from exposure if an appropriate cancer slope factor is available. We use this evaluation to reach our public health conclusions and make recommendations for reducing harmful exposures. Up until the last year or so, we had pretty much worked out the tox studies we referenced and language about sensitive endpoints and effect levels for our PFAS work. And we had standard language about how PFOA and PFAS were suggested as carcinogenic, but we couldn't quantify the risk because no cancer slope factors were available. But as I mentioned earlier, several changes have taken place recently. Changes in the health endpoints, effect levels, cancer classifications, and cancer slope factors available for several PFAS mean we need to update these parts of the evaluation. Now, the general process we follow hasn't changed, but I'm going to talk about the newly introduced health guidelines based on PFAS science that will require changes from the way our most recent PFAS documents have discussed and reached conclusions. Because the changes introduce significant complexity, we're still ironing out exactly how this will be implemented in the evaluations moving forward. Today, I'm going to focus on telling you about the changes and discussing general thoughts about the implications for our evaluations. So up until pretty recently, the only official CVs we had available for screening PFAS were the intermediate EMEGs based on our intermediate duration MRLs from the 2021 tox profile. Because the intermediate studies were based on steady state PFAS blood levels in the animals, we considered these protective for chronic exposure durations. But over the past few years, EPA has finalized chronic oral reference doses, or RFDs, for several PFAS. When available, the CVs derived from the RFDs, called RMEGs, have replaced intermediate EMEGs derived from intermediate MRLs as the recommended CV for screening in FAST. I'm going to show the health guidelines and CVs in a moment, but first want to explain that several of the new RFDs are very low, and to make my tables easier on the eyes, I have converted the units to show dose in nanograms per kilogram per day and water concentrations in nanograms per liter. A nanogram is 1/1000th of a microgram and 1/1,000,000th of a milligram. FAST reports dose and concentration in different units, so I've listed conversions used on this slide. This slide shows the current health guidelines, ATSDR minimal risk levels or EPA reference doses available for PFAS and reported in FAST. Note I've converted these to nanograms per kilogram per day, as I mentioned before. You can see from this table that the chronic RFDs for PFOA and PFAS are much lower than the intermediate MRLs. Two notes. First, I understand EPA is in the later stages of finalizing toxicological reviews for PFHXS and PFNA, the only two we still don't have chronic values for. And second, our toxicological profile for perfluoroalkyls is also nearing public comment release, and it's possible MRLs may be added or changed. So this table may be out of date in a few months. The health effects that are the basis for the health guidelines are also listed on this chart. You can find more information in FAST on the health guidelines page for each contaminant. That page has links to relevant references and for some PFAS, a summary of the principal study. This slide shows the current recommended drinking water CVs derived from health guidelines from ATSDR's FAST tool, converted to nanograms per liter. The ones labeled RMEG are from EPA chronic RFDs, and the EMEGs are derived from our current intermediate MRLs. An obvious issue is that a few of the RMEGs are very close to the detection limits for these PFAS. So for practical purposes, you'll never screen out those PFAS if they are detected at all. And it is a requirement that the FAST recommended CVs be included in screening tables in your ATSDR documents. Some cancer classifications for PFAS have been changing too. Both IARC and EPA have increased the cancer classifications for PFOA and PFAS in the past year. And EPA has finalized oral cancer slope factors for both PFAS. I'll note that the cancer slope factor for PFOA is such that if we developed a CREG, it would be even lower than the RMEG and below typical detection limits. At any rate, with these CSFs, we will now be adding a quantitative estimate of cancer risk to our evaluations. So with all these changes to the science and values used in the process, those of you working on sites might be wondering how to move forward with evaluations that you might have been working on for some time. I do have some ideas on moving forward that I'll share. These are my personal thoughts, and you and your team might find completely different ways to accomplish our mission, so don't feel bound by any of the things coming up. I want us to keep the big picture in mind, so I'm showing ATSDR's vision statement from the ATSDR mission, vision, and impact page of our website. ATSDR's vision is most trusted agency protecting American communities from environmental health threats through application of state-of-the-art science. This statement contains a number of things relevant to PFAS evaluations that we're trying to keep in balance. First, we protect people from harmful exposures, and we focus on the most harmful exposures first. So we don't want to slow down or stop our work because new science has come out or things are changing. In fact, we welcome and use new science when it's properly vetted. And to maintain trust, we apply new science in a transparent, consistent process people can understand to reach conclusions and make recommendations to protect public health. So great, but in practice, how do we keep moving forward with our site work when everything is changing? Well, in my opinion, I think it's important to just move forward with what we know today. It's important to keep working on assessments so that we can make meaningful and timely recommendations to reduce harmful exposures. The second thing is while you're moving forward with evaluations and assembling documents, I'd recommend keeping tabs on things that might be changing soon so you know what tables and sections might have to be updated when, for example, EPA finalizes those last two tox reviews or ATSDR releases the updated tox profile. If the project lead or author stays organized, it'll be tedious to change, but it should not require a full rewrite of the document. And third, as far as I'm aware, most of the new science is pointing towards effects at lower exposures than we were aware of previously. It's not changing the fact that we're concerned about those high exposures and possibly more concerned than we were before. So finally, as you move forward, keep in touch with your technical project officer and your associate director for science group so everyone's on the same page and can share information to keep everything on track. And finally, I also want to touch on a question I've heard about the new low effect levels. Given that any detectable level of some PFAS could increase the risk of cancer or non-cancer health effects, how do we provide health protective recommendations when the levels of concern are below EPA MCLs and current cleanup capabilities? In the current regulatory and scientific environment, this seems possible when evaluating for PFOA, PFAS, PFDA, and maybe an increasing number of PFAS in the future. Well, if that's what the science is saying, we have to follow that. But as I mentioned before, higher exposures are always going to be of higher concern. So we might need to think about placing the findings at each site into perspective a bit more. Maybe focus our strongest recommendations on ways to reduce those highest exposures first. For the health effects at or around detection limits, we might need to consider developing some standard language that's there is always some risk, like the language we have on no safe blood lead level or asbestos where no exposure is without risk. Similarly, if we find a concern for an area that doesn't meet the criteria for cleanup action, we can recommend other actions to protect public health, such as community engagement to raise people's awareness. This slide has links to ATSDR's other work on PFAS for your reference. It includes links to the toxicological profile for perfluoroalkyls, PFAS exposure assessments, PEAS and multi-site health studies, PFAS information for clinicians released in 2024, and the PFAS blood level estimation tool. This slide has links to several resources on the PHA process, the online Public Health Assessment Guidance Manual, Public Health Assessment Training or FAT, and the Public Health Assessment Training webinar series. It also includes a link to the 2018 Mixtures Framework. I've put my email address azd9@cdc.gov on this slide if you'd like to send a specific question by email. Or you can always reach out to your TPO or ADS group for your office. Thank you for your attention today.